Hello, everyone. Thank you for joining us. This is EP Talk, the place where EPs, emergency physicians, come and talk about things that are important to us. Sometimes it's personal, professional, but sometimes it's clinical. And today I have my very special guest, Dr. Nicole Haig. And we're going to be talking about when you don't need to prescribe antibiotics and what kinds of tools that are helpful to make that happen. One of the things that, to set this up, Dr. Haig, we've just been through 2 years of pandemic dealing with viruses. And I'm going to let you talk about yourself for a second, but I'm just sort of setting the audience with the expectation that we've reflexively written antibiotics for a lot of things. And that's what we're going to be talking about in a second. But first, tell us a little bit about yourself.
Well, thank you for having me today. My name is Nicole Haig. I'm a board-certified emergency medicine physician. I've been in practice now for 22 years. Can't believe it's been that long.
Yeah.
And I just really enjoy the art, which I think it is, of practicing emergency medicine, right?
Yeah.
It's a very fluid process. It's one of those specialties where you have to stay on top of things. And
Right.
one of my real passions has been antibiotic stewardship.
Yep.
I've seen, as we all have, no matter how long you've been in emergency medicine, 5, 10, 20, 30 years, just how much we've abused alcohol. I mean, see, I want to say alcohol because it's like an abuse, right? We've abused our ability to prescribe medications.
Yeah.
And it's not because we're not good clinicians.
No.
And there's so many factors that play into it, right? But now that we know that there are so many negative impacts that come along with this, may it be, side effects from medications or just having all these antibiotics now that don't work, right? And we have all this resistance that's in place.
Resistance, yeah. We got a lot of resistance going on,
right?
all kinds of things. So
what do we do about that? Like,
right.
How do we change our clinical practice where we still are protecting the patient? Because ultimately, no matter what we do, we still need to be doing the right thing for the patient. And I think that we have tools now that are helping us be able to make those decisions in our everyday clinical practice.
Let me go back to the intro and say that, having gone through COVID for the last 2 years, we are all, obviously this has been a pandemic that's killed millions of people worldwide. And so we have, every time we've seen COVID, we've sort of reflexively added on, well, it could be community-acquired pneumonia as well. And then so we reflexively give them antibiotics, and they're not always really necessary. In fact, I wouldn't say seldom necessary, but the numbers are small, are they not?
They are. They're actually very small. I mean, what we've seen in clinical practice and what the studies are showing us is that the vast majority of patients who had COVID, really, it was purely viral. Yeah. Which meant that the reality was that we did not need to give them antibiotics. But to be completely transparent in this process, right? Part of the reason why we gave antibiotics is because we just didn't know.
Right. You can't tell. I mean, it's a safety, it's a fallback. It's a safety. Exactly. It's a safety issue. Well, maybe they've got this, so I'll just throw in some antibiotics and I'll wait till cultures come back in 48 hours or whatever, or maybe I don't. And we'll wait. We'll see if a pneumonia develops, and there's a lot of different rationales depending on where you practice. If you're in a university setting or versus a community setting, you might just prescribe the antibiotics and let it run. Someplace else.
And the problem with that is, there's really not a lot of oversight as far as giving clinicians feedback to say, look, this is not something that you need to do. Because I can tell you, as someone who practiced not only in the emergency department, but in the ICU for the past 2.5 years with this, it was something that I was forever feeling pressured. I felt professional pressure to give antibiotics, because when I didn't, the question that I got from the infectious disease doctor was, why are they not on antibiotics? And I said, but we have no indication at this point as to why we should be giving antibiotics. Right. And it's a discussion that we continue to have. But as we educate clinicians, at every stage of their practice, no matter if you're at the beginning of your career, in the middle, or towards the end, the oversight, the same theme remains the same. We have to be aware of what we're giving patients, from the patients that we see that are, our common colds,
Yeah.
quote unquote, all the way up to our patients who are the sickest patients in the hospital. We really need to figure out, do these patients need antibiotics? First and foremost, that's
Right.
the first part of our decision tree.
Right.
And then for those patients that are admitted, when do we stop? And
Right.
that's, part of the reason why I've been such a proponent of procalcitonin.
Right.
And I will tell you that this is something that I've used now for the past 18 years. And I was fortunate enough in my early career that I worked very closely with a pulmonology group who also were our intensivists at the facility where I was working. And they're the ones who introduced me to procalcitonin. I had no idea what it was. And
Sure.
they were noticing that out of the emergency department, that we were prescribing a lot of antibiotics for our patients, especially those patients that had the lower respiratory tract infections. And they were the ones, who said to me, you might want to consider using this test. And
Yeah.
I have just found procalcitonin to be so helpful throughout my career in making that decision and making it with confidence and
Yeah.
knowing that ultimately I'm doing the right thing for my patient, which is what we're all trying to do.
Yeah. Yeah. Back up and let's kind of outline the factors that would go into deciding to give empiric antibiotics in a patient that presents. We put it in the setting of COVID, but just community-acquired pneumonia. What are the factors that would make you lean toward giving antibiotics in community-acquired pneumonia, or did we just do it reflexively? He's got CAP, he gets antibiotics.
Well, looking at the patient, there are lots of things that would factor into whether or not a patient gets antibiotics. And so we have all these tools, right? We have their vital signs. We have our white blood cell count. We have our lactate. We have our procalcitonin. We have the chest x-ray. We have the history of present illness. We have their comorbidities. So we are putting all of this together. It's not, as we all know, there's no one right way to treat any patient. And so that's why we try to use the tools that we have in place to try to make that decision. So if I have a patient that comes in who's presenting with pneumonia and they have a fever, they're hypoxic. So my first concern is, what do I do emergently to help this patient? Well, I'm going to do my test. I'm going to minds of sepsis. And then I'm also going to do a procalcitonin, because a procalcitonin is going to give me a very quick idea within an hour of whether or not this patient is potentially showing signs of a bacterial infection.
Sure.
And so once I get those results back, I put them all together. And you'll hear this come from me over and over again. There's not one test that's the end all be all. We have to use everything that we have to make the best decision possible for our patient at that time.
Okay, I'm going to flip the equation around, okay, because in a world in which antibiotic stewardship is a big issue, everybody is on the outside pressing us to be able to write fewer antibiotics. In a patient admitted with severe community pneumonia, what cases would you be confident in not prescribing antibiotics? What would be the setting that you would look at that and go, I'm going to send them upstairs or I'm going to send them home, but whatever it is, I'm not going to write antibiotics. What would be the factors that would be likely to swing your decision toward not writing antibiotics?
I think once again, it would be looking at the patient's vital signs. If someone is hemodynamically unstable, if their blood pressure is low, if they're tachypnic, if they're tachycardic, they're febrile, and all of these things together, because it's not just one vital sign either. And then if I was to go ahead and do my lactate, and my lactate is less than 2. And then if I do my procalcitonin and my procalcitonin is less than 0.25, well, then I'm having all these things coming together telling me that this is not necessarily, this is not showing me that this patient has a bacterial infection. That doesn't mean that they don't have a very serious viral infection, in which case that I have to think about giving them other medications, maybe antivirals or steroids or whatever it may be to support them. But if those, especially if I'm using my lactate and my procalcitonin together, plus minus my white blood cell count, because we all know, white blood cell counts can be plus or minus, right? Because if someone has other comorbidities, that number may be falsely deflated or falsely elevated. Yeah. And so again, it's bringing it all together. It's just, it's like putting a creation together in a kitchen.
Yeah. Switching, I got a specific question to ask you. Is MRSA in your mind a community-acquired pneumonia pathogen? Talking specifically about MRSA.
MRSA is less often a community-acquired pathogen for pneumonia. We see MRSA all the time, right? Because we see these patients who come in with abscesses, but as far as community-acquired pneumonia, not so much. The studies don't show us that. And I'm big into studies. Like, I want to see the evidence. I want to know, because maybe what I'm seeing in my clinical practice is not necessarily representative of the whole picture. And so I try to put it together between what I see in clinical practice and what I'm able to review in these studies. And between my clinical practice and the studies that I've reviewed, MRSA is not big, and is not a big pathogen that's contributing to CAP.
Let's talk a little bit about concordance of CRP and PCT in antibiotic stewardship. When do you what do you look for between CRP and PCT readings?
Okay, so again, there's no end-all be-all test. CRP is a great test, but it's not specific to bacterial infection, right? CRP can be used for any sort of inflammatory process. So an elevated CRP is not telling me that I have a bacterial infection. So if that's what differentiates procalcitonin from a CRP. And that's why we're seeing fewer and fewer people actually use CRPs. It's really our orthopods who still really use CRPs at an extensive level, at least what I see in my clinical practice.
Okay.
We see a lot more procalcitonin, because procalcitonin is not only, sensitive to telling us if this is a bacterial or non-bacterial infection, it's also specific. Yeah. And that's where the discordance comes with CRP.
So you're saying that if you got an elevated CRP and PCT levels were not so elevated, you'd be very inclined to say that this is most likely viral than bacterial.
Correct.
Yeah, because CRP really is. I think you're absolutely right. CRP just looks as a broad inflammatory marker. We're concerned when we see elevated CRPs. It just doesn't point us anywhere. It just tells us that we've got patients got a problem. We don't know where it's coming from.
Exactly, and that's why we need tests and tools that will kind of gear us, guide us where we need to go. Especially for us, we don't have the luxury of internists and intensivists who have days potentially to review material. We have minutes and hours.
Yeah, and I think that actually is the reason why people sort of default to writing antibiotics, is because they're really aversive to risk. And when what the heck, I was talking the other day to our board, and I was asking about when they use PCTs and I'm sorry, procalcitonin, and they were just saying, well, I get it, and I start them on antibiotics, and I let the intensivist make the decision. And I thought, that's kind of a punt kind of mentality.
It is a punt, but everyone is CYA, right? Yep. Unfortunately, we make up 5% of the world's population, but 95% of all lawsuits. So with us working, in this very limited amount of time to make some of the most life impacting decisions, people feel the pressure to literally, a lot of times, just throw the kitchen sink at a patient, And,
Right.
and I get that. I get that. But at the same time, we have tools in place that can help us make better decisions. I mean, one of the most common things we see is COPD exacerbations. I have this discussion all the time with my colleagues. I'm like, just look at the procalcitonin. The studies tell us that the vast majority of COPD exacerbations are viral. So why are we giving antibiotics? But everyone's always afraid. They have all this angst, but use the tools that we have. You know, as time has continued to evolve, we have these tools that can help us in a very short period of time make good decisions about whether or not to give those antibiotics. We just need to use them.
Just talking about the COPD made me cough.
Sorry.
No. I've been with my grandchildren and they've made me sick, and I guarantee you it's a viral infection because they have one viral infection after another.
Exactly.
And and we just sort of put on blinders when we see people coming in with what appears to be COPD exacerbations or with community-acquired pneumonias or things like that. And you're right, we just sort of reflexively give them antibiotics, and then maybe somebody later will take them off. But we could be practicing a lot smarter, and not just being academically correct, but as you are, I'm sure, very familiar, writing antibiotics that we don't need to have has a downside, has a significant downside. We're having pathogens that we have are developing resistances to our antibiotics that we're having to get stronger and stronger and stronger with more and more side effects. So there's a good
Absolutely.
reason.
I mean, that's something that there are lots of good reasons though. Besides, resistance, we have all these patients that come in with C. difficile has always been a big one, but we have patients that come in with all sorts of side effects from these medications.
Yeah.
They can have gastritis, gastroenteritis, an acute allergic reaction, may it be with urticaria or just a general intolerance. That's one factor. But what about cost? In a system that where our constituents, our patients, our population is so overwhelmed with medical costs, why are we necessarily, impacting that bottom line for our patients with something that they don't necessarily need?
Right.
Especially for our patients, so many Americans, millions of Americans who are uninsured or underinsured, they don't need that extra charge if they don't need it. Now, absolutely, if a patient needs antibiotics, then we give them what they need, but we have to be very aware of what we're doing. And as that resistance, just like you said, continues, I mean, these antibiotic names are getting longer and longer and longer because now we're like tripling antibiotics to create this new antibiotic. And when you give it to them, it's like, okay, well, now you have to think about the renal side effects, the hepatic side effects, the cardiac side effects. It's like there are all these side effects that are coming from these medications. Well, why don't we just take it back and take it back to the simple stuff? Let's just start with the simple stuff. And we can, as we go through, just even with our fast track patients come in with the expectations now that we're going to give them a Z-Pak if they've been coughing for 2 or 3 days.
Right.
The studies have overwhelmingly showed, multiple studies that have come out of Europe, have come out of the Middle East, have come out of the United States, that the vast majority of those patients don't need antibiotics. And even studies that have been done with procalcitonin, when they've tested their levels, there was a reduction of up to 75% of antibiotics that were given to patients on an outpatient basis. Think about that. 3 out of 4 patients did not get antibiotics because they were able to do a simple test that reinforced what the clinician probably already knew, but was afraid or hesitant, let me say, to do without this test.
One of the things, and we're getting to the end of our time, but one of the things that you bring up here, and I think this is very, very valuable, because oftentimes I found with my patients, I really have to sell my diagnosis. Okay. If I go to them and I say, you really don't need antibiotics for this. And they'll say, well, how do you know? Okay. And this is where you come in and say, well, we actually have a test that is able to, that's pretty specific for bacterial infections. And you can make the case that you can sell to the patient that, I'm really going to benefit you by not giving you antibiotics. It has all kinds of side effects. I always bring up my mother-in-law who got C. diff and almost killed her almost killed her when she got antibiotics for something that really shouldn't have gotten in the first place. And so that test is able to provide me with a little bit of rationale, credibility. I don't know, however you want to say, so I can say to the patient, and they'll feel comfortable not getting antibiotics, because otherwise, I mean, we all know patients walk out the door. Doctor, you don't know anything. You didn't give me antibiotics.
They didn't do anything for me. They
you
just
didn't do
didn't
anything
do
for me.
anything for
You
me.
didn't,
Right.
yeah. But if you're able to explain that, no, there's this test that's pretty specific for bacterial infections, and it's pretty low. So I think we're not going to give you antibiotics, and maybe that is one more step in educating the public to say, I really don't need to have this. And
it's a huge step. It's a
yeah.
huge step. But again, it will need education, right? It's gonna take some time for us to also educate patients, because if we tell them about this test and educate them and let them know that, this test is credible and it can really, give us an idea of what the best treatment plan is for you. And again, what I always emphasize is I am doing the best for you that I can. My intention is to treat you the way that I would treat my sister or my brother or my father or my mother. And procalcitonin gives me the opportunity to do that and to do it with confidence. Either way.
That's great. Well, anyway, I thank you everyone who's been listening in to joining the conversation. I think that it really does stimulate our desire and curiosity to practice medicine more accurately. And I think that we all know that unneeded antibiotics have side effects, as we've said, not just the resistance, but also other types of problems like C. diff and other things. So give it some thought. And Dr. Haig, thank you for joining us today. And if you'd like to have more conversation with Dr. Haig, can you provide us a contact point? Are you able to do that?
Yes. So you can always reach out to me on social media. I am on Instagram at Dr. Dr. Nicole, Nicole, the Pulse, like our pulse.
Dr. Nicole the Pulse.
Yes.
Okay. Great. Thank you very much for joining us. And I hope everyone has learned something today. And we'll catch you next time on EP Talk.